afternoon. I'm doing great. How are you?
I'm good, thanks. So just for those people who are watching this video, Dr. Shah is a urologist based in the United States, and we're going to talk a little bit about erectile dysfunction in men, and more specifically penile prosthesis, which is surgery that we can offer to patients who have refractile erectile dysfunction not responding to other treatment options. So, Dr. Shah, thanks so much for giving us a bit of your time. How common is erectile dysfunction amongst healthy men in your population?
Yeah, that's a great question. So erectile dysfunction is more common than we otherwise think. Most men think they're alone because they have erectile dysfunction, and it's a sensitive topic. So for that reason, most men don't seek out help. They assume it's just an age thing and that, it's inevitable and there's no fix for it. The actual rates are 1 in 4, and that's for all men in general. So that means a quarter of the entire male population. So a quarter of 50% of the world have erectile dysfunction. As you get older, it becomes more common, not necessarily just because of age, but more so because of the comorbidities that come with age, right? Diabetes, heart disease, prostate cancer treatments, hypertension, all these things are risk factors for erectile dysfunction. And so all of that comes together. And so as you get older, you're more likely to see erectile dysfunction. But just in general, a quarter of the entire male population in the world have erectile dysfunction.
Yeah, in South Africa, there's a statistic that says at the age of 50, only 50% of men can achieve functional erections without assistance. So it just goes to show how common it actually really is. And in your situation, the link between cardiovascular disease and erectile dysfunction and diabetes, do you guys also see an increase in that in your population?
Yeah, absolutely, right. Worldwide, and the link is, if you understand the pathophysiology behind it, it makes sense, right?
Yes.
Cardiovascular disease. So that means that arteries are getting clogged. Atherosclerosis, right? Hypertension leads to atherosclerosis. Diabetes leads to atherosclerosis. So just plugging arteries getting clogged would cause erectile dysfunction. What is erectile dysfunction? It's poor blood flow going into the penis, right? When the penis engorges with blood, that's your erection. So if you have anything that impedes blood flow, then that can cause erectile dysfunction. Typically, patients will get erectile dysfunction before they even show heart disease, right? And that's because the blood vessels for the erections are smaller than the blood vessels for the heart. So a lot of our patients, if we see erectile dysfunction, we'll send them to get their heart evaluated because it's possible we're missing heart disease in the process. So you can see that there's a clear link between that. Diabetes honestly causes it has more than one reason for erectile dysfunction. Number one, diabetes causes neuropathy, right? It impacts nerve sensation. That nerve sensation is important because the nitric oxide that allows an increase in blood flow when you have an erection is released from the nerves. So if there's some impedance there, you're going to see worsened erections. Diabetes is a risk factor for heart disease. And we just talked about how that impacts blood flow, right? And diabetes has a link between, there's a strong link between diabetes and what we call venous occlusive disease. What that means is, as normally when the penis engorges with blood, what it's supposed to do, it's like a balloon. What it's supposed to do is squeeze the veins on the outside of the penis shut. And by squeezing those veins shut, the blood stays in the penis and you can maintain your erection. Venous occlusive disease means the erectile bodies have lost their ability to stretch. And when they can't stretch, you get a permanent condition called venous occlusive disease where the blood goes into the penis and just leaks right back out. All of those are reasons for erectile dysfunction. And there's a very strong link between heart disease, diabetes, high blood pressure, and erectile dysfunction.
Yes, yeah. We see something similar in our South African population. If you broadly had to classify treatment options for patients with erectile dysfunction, and how would you broadly classify the options that patients can access to manage their erectile dysfunction?
Yeah, I think that's a great That's a great question, right? The pathophysiology is important, but what's really important is how do we fix it? We always start patients with an oral medication if available, right? So see if that'll fix it, because that's the least invasive thing you can do. If that works, and that works maybe half the time, it works less often in patients with diabetes, more often in patients that don't have diabetes. But if that works, then great, we found a solution. It is temporary, right? But at least it's a solution. Now, there are problems with that. It sometimes is unaffordable or unavailable, right? And so that can pose a problem. If that's not an option, we try injection therapy or vacuum erection devices. There are things called intraurethral gels or pellets that you can use, and those are pellets that you can put inside the channel that you pee out of. And sometimes those things help, but those are not perfect either. Sometimes some of these options can cause erections that last too long, and that can pose a problem, right? And so it's not a perfect science. If none of those are options, either for cost reasons, ineffective reasons, or they're causing pain or other problems like erections that last too long, that's where penile implants come in. And penile implants are an awesome, awesome, awesome option with very high satisfaction rates. And they sort of bypass the whole problem by giving you another mechanism to have erections. And so, it's just an awesome, awesome option that we're able to offer our patients. It's like a surgical fix per se, and it allows them to not have to deal with the stress and anxiety that comes with trying these other options but failing with them.
Yeah, I fully agree. I always tell my patients it's an on-demand erection that lasts as long as you require it to last, which is really, really great.
And I think that's a great way to put it too.
At what age do you think patients should consider surgery, or which age group do you think it's more appropriate for?
Yeah. The older they are, the better they're a candidate, right? Because if you think about it, a penile implant, the lifespan of it can be as long as 30. I've seen it last as long as 30 years or longer. But in general, we say the lifespan is about 10 years. The data actually shows 88% of patients at 10 years, they're still going strong. But we say about 10 to 15 years. If they're getting it at age 20, they're going to need a lot of surgeries in their lifetime, right? Because in 10 years, they're only going to be 30. And in 10 years from there, they're going to be 40. And 10 years from there, they're going to be 50, then 60, then 70. That's like 8 surgeries in a lifetime. So the older you are, the better you're a candidate because you're less likely to need another revision surgery. And every revision surgery can get a little bit more complex. There's a little bit more scar tissue, slightly higher risk of infections, right? So the idea is if you're older, you're going to be a better candidate. But I'll tell you, there are a lot of young people who are great candidates, right? Because they've tried other options, they had a erection that lasted too long, and now they have severe scar tissue and can't have an erection again. So there's truly no age limit. Obviously, if you're younger, I would recommend you try some of the other options first. If you're older, this may be a second or third line treatment for you.
This balancing act of people who are, let's say, for instance, in their 60s, they consider themselves to be too young for surgery, but at the same time, they now lose the ability to be intimate with their partner due to failure of other treatment options. I always say, also, don't wait till you're 70 or 80 before you get your penile implant. If nothing else works, then it is worthwhile to consider using it.
Yeah, and I think for a couple of reasons, right? When you're 60, you're also a better surgery candidate. You're healthier. Don't wait till you're so unhealthy that you can no longer have surgery, right? You're also giving up the prime of your life, right? So when you're 60, when you have a penile implant, you truly enjoy it. You can have sex whenever you want, right? And that's an amazing trait. Very few people in the world can say that.
Exactly.
If you wait till you're 80, your heart may be what prevents you from having sex as long as you want. So, you're almost like Superman right after an implant. And if your body can handle it, your life is going to be better. If you wait till you're too old, you're going to lose that opportunity. So during the prime of your life, you want to take advantage as well. So.
How do you counsel or approach patients who are sort of on the fence about getting surgery, whether they really want an implant or not?
Yeah, I mean, I never push a patient to have surgery. I do have patients that have had surgery who are now patient educators. I do give them an opportunity to talk to them. I always encourage them to have their loved ones come with them. It's their wife, their partner, come come with them for the visit, because usually I'll tell you, it's not the patient that's as worried as it is the partner, right? Because the thought of surgery and an elective surgery is scary, right? It is a minor surgery, it's a low risk surgery, but it's not a zero risk surgery. There's no such thing as a zero risk surgery, right? And so when you have a partner and you tell the partner, hey, I want to consider a surgery for something that's not life threatening, their first thought is, whoa, 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 it's surgery, right? We can live without sex, but it's surgery. It's too scary. So, I mean, I think it's important to have them come in, both the partner and the patient, so that the partner gets to ask their questions too, understand the risks, the benefits, the advantages of having this surgery. And like usually that'll give them an opportunity to talk together. And I always let the patient make the decision themselves. I personally think it's a no-brainer. And I think by the time we're done talking and answering all the questions, most patients agree.
What can patients sort of expect on the day before and then on the day after the surgery?
Yeah. So, the day before, there's always that built up anxiety, right? I always tell them, look, just relax that day, take it easy, get some rest. Obviously, don't eat after midnight the night before. They show up the day of surgery. I have a talk with them that usually calms them down. They get some antibiotics to start, and then we roll back. When they wake up, I do use a local block. So I numb the nerves locally, and that tends to limit postoperative pain. They wake up, usually pain-free, and then they go home. And then a few days later, I see them in the office. We talk again. I remind them of all the common things, what to expect, swelling, etc. Expect some swelling. Swelling is common. It will go down. Okay. Talk to your surgeon if you're concerned about anything. But in general, it's not a super uncomfortable healing period. After about 2 to 3 weeks, you start seeing the swelling go down, and then you start noticing what you've had done. And typically after about a month, you're ready for surgery.
And
I'm sorry, you're ready for sex.
Ready to start using your fancy device.
Yeah. It is. I will tell you, it's a little tricky because some patients get so excited they want to use it the next day. And when I give them a local block that reduces pain, they don't have much pain, so they really want to use it. It's like a Maserati or a Ferrari that you have to leave in the garage, and you can't take it out for a month, and that's a little challenging for a lot of people. So I do try to counsel them. Look, it's really, really important that you heal before you do anything.
And in terms of recovery, in your experience, how many days do you generally book patients off work, or how long do you give them to before they can start exercising again and things like that?
Yeah, so I tell them about a month before exercise. It depends on what they do for work. Light duty after about 10 to 14 days, and they can pick up normal duty after about 4 to 6 weeks. No soaking in any kind of pool or jacuzzi or water or tub for 2 months. That's a hard rule. And but outside of that, usually around a month they start picking up normal activity, and they're back up on their feet. Some patients work from home or they do very light duty and they choose to go back to work earlier. I say at least give yourself, a week if you can off just to start the healing process. And if it's super light duty, or you're working from home, I mean, in theory, you could probably do whatever you want. So what do you counsel them?
No, so very similar to you. Obviously, for us, cost is a big issue in South Africa. So we do try and limit it as far as possible. And one of the things that we do is we try and limit hospital stays. So we often discharge these patients either on the same day or the next day, at the latest the next day. And then so there is a bit of recovery at home before they tend to go back. So like you say as well, I usually say 10 to 14 days before you're back at work, back in the office.
Yeah,
And then
I think that's perfect.
that they can't immediately use the prosthesis. I think that is something that I sometimes forget to tell them, that after surgery, you first have to wait for a little bit. There is a bit of a recovery time.
Yeah, and I think that's important. And we do all our surgeries outpatient. I very rarely admit or keep a patient here. There are rare cases where I might, mainly for ride situations. Sometimes they don't have a ride, so they'll stay. Then I'll do it in the hospital. I'll keep them overnight so that anesthesia wears off, and then the next day I send them home. But it's it's very, very rare that I keep any patient after one of these surgeries.
Yeah. And then, like any surgery, there are a few negative side effects that I think is also important to just mention to patients. And in your experience, what do you normally tell them? Like, what are some of the downsides of the surgery?
Yeah. So I mean, so the number one negative is that once you have the surgery, right, you cannot go backwards. So once you go implant, right? You can't say, okay, now I want to try injections. Now I want to try oral medications, right? It doesn't work that way. Once you go implant, you go implant. So I tell every patient, look, if you want to try something else, try it now because you're going to lose that opportunity later. So get it out of your system so that when you're ready for an implant, you're ready for an implant. There are rare risks of infections, which can happen with any prosthetic in your body, hip replacements, knee replacements. It's a risk, right?
Yes.
So that's something to keep in mind. It's not that common. The risk is like somewhere around 1% with penile implants, but it's not 0%. So you have to be prepared. And I tell patients, in the event that you're that 1% that where it occurs, you got to be mentally strong and mentally prepared and know you still made the right choice. And that's why I say, if you want to try something else, try it now. So I think counseling is important. The beauty of this is you can have sex whenever you want for as long as you want, but the implant can break. And if it breaks, then we have to replace it. It is very replaceable, but you do have to replace it. So just keep that in mind. It's like a car. If you crash the car or the car breaks down, you're going to replace it, right? And so this is no different. If you take care of it just like you would your car, it's going to do great. And
No,
at some point, yeah.
I agree. So as long as it's as long as you maintain it and you're not risky about it, then it generally does work quite well. And then a lot of patients in our setting is quite concerned about penile shortening. I find that it's not that significant, mostly slightly noticeable if you really look for it. In your experience, what do you think?
Yeah, it's all about surgeon comfort and sizing. I will tell you a large volume of the patients that see me come to see me because they're concerned if they go elsewhere, they'll get penile shortening. And the key is really sizing. If you make a measurement, you put in that measurement, or you can even go up slightly on the measurement, they're probably going to do fine. If you make a measurement and you're like, well, let me just go a little bit shorter on the implant just in case, well, then they're going to be a little bit short. Right. And so it's a little bit about confidence, but in general, what it is most patients have lost some size before they even have their surgery. And that's from years of not having good erections. It causes penile contractions. I do have patients use a vacuum erection device ahead of time to try to reverse that disuse atrophy, right? That penile shrinking that occurred from not using the erection. It's just like a patient that has spinal injury, right? And then now they're paraplegic. They can't walk on their legs. Or if you look at their legs, they're shrunken. They've lost muscle. They've lost tone, and we call that disuse atrophy, right? The penis is the same way. If they're not using it, if you're not using it, you're not getting regular morning erections, it's going to shrink. If you're waited a while to get your penile implant, you've lost length, and you don't realize it because the last penile length you remember is when you had good erections. And so now you have surgery, but your penis is not as long as it used to be. And we can only put in the size that your body will let us. So, those are things to keep in mind. If you wait too long to have your surgery, you're going to have a shorter penis. And that has nothing to do with the surgeon, but more so to do with just your natural body.
Yeah, no, I fully agree. And often find that patients might think that there's a little bit of shortening, but their partners really don't care and don't really notice it at all. But we as men tend to look at things slightly differently. We're always quite hard on ourselves.
Yeah, agreed.
Right. And then I hear that you are coming to South Africa to do a few cases here.
Yeah, I feel very privileged to be able to come down there and operate with great surgeons like yourself, and so I'm very much looking forward to it.